Hello, good evening, everyone. So welcome back to another session of random MCQ discussion. This is going to be part 4 for the month of May. All right, before we start, can somebody let me know whether you can hear me and whether you can see the screen so that we can start with the session. Okay, thank you very much for the reply. All right, so let's start with today's session. As usual, we'll be discussing few selected MCQs today as well. So let's start. So this is going to be the first question for today. This ECG has been given with a clinical scenario and saturation had been 98%. What is the management? So the plan here is to identify the ECG and to identify the clinical condition and to come up with the management. Assume that this is an adult. We don't know about the age and other things in the clinical scenario, but just assume this is an adult. Okay, I'll give you some time to think about this. So you have three answers here. Answer A is indomethacin, answer B morphine, and C oxygen. So what do you guys think? Okay, I'm getting a couple of answers, but I'll wait for the majority of the group to respond. Almost all of you think it's answer A. So answer A is indomethacin. Let's see if anybody thinks otherwise. No. So almost all of you think that this should be managed with indomethacin. All right, so let's have a look at this question. So here you have this ECG. Now ECG identification is a very important component that you should master because you will, or most of the time, you will get an ECG to identify. Like, so the common conditions that you would be tested would be your STEMI or the acute coronary syndromes, then this CCG, which we will identify later, and the arrhythmias, which are the most commonly tested area. So different arrhythmias and the MI or acute coronary syndrome, and this ECG is a common ECG that you will usually get. Okay, so when you have a look at this ECG, the most striking feature, now here you can see the rhythm is almost the same. So this is a sinus rhythm. The patient is in sinus rhythm. You can't see any arrhythmia here. So that we can make sure. So this is in sinus rhythm. So when you take the heart rate is also okay. You don't see any tachycardia or bradycardia here. So we have sorted out that. So the most important things that you have to answer when you see an ECG is to check whether there is any sort of heart rate derangement. In other words, whether there's any tachycardia or bradycardia. So that is a question that you have to answer with an ECG. So here you don't see any tachycardia or bradycardia. The heart rate seems normal. So then the second question you have to answer in an ECG is whether there is any arrhythmia or any rhythm abnormality. Now here you can see this is a very well, you can very well see that there is no arrhythmia. So this is more or less in sinus rhythm. The third component that you have to answer is to look at the individual waveforms. So you have to see whether there are any ST segment abnormalities, whether there are any T wave abnormalities or P wave abnormalities. So you have to answer that component. So that is like a detail or a very good guided approach to come to a diagnosis in ECG. Now here we answered the rate, so it is okay, the rhythm, all right, sinus. So when you look at the other component or other waveforms, here you can see the striking abnormality that you see here are the ST elevations. So you can see here, ST elevations can be seen in almost all the leads. Now see here in V1, V1 to V6, you can see ST elevations. And in other leads also, specifically 2, 1, 2, like you can see a global ST elevation in this ECG. So that is a very important phenomenon that you can note in this ECG, and that is the striking abnormality that you see. So whenever you have a ST segment elevation, the two important differential diagnoses that should come to your mind are your acute coronary syndrome, that is your STEMI or ST segment elevation MI, and the next thing, like you all have said, is pericarditis. Okay. So those two are the most two important differential diagnoses. So how do you say whether this is an MI or a pericarditis? What are the features suggestive of a pericarditis here? So can you guys just give me some inputs on that? How do you say this is pericarditis and not a STEMI? Okay, I can see one answer. Yes, diffuse elevation. Very good. That is a striking abnormality. So in ST segment elevation MI, you see this ST elevation in a particular region that is relevant to the heart's area, which is supplied by a particular artery. You don't see a diffused elevation in most of the STEMI. That is number one. Number two, yes, very good, the saddle shape. So that saddle shape or a concave shape in pericarditis, you see. So let me take you to that slide since I have answers from you. So like I said, here you have in acute pericarditis, you have a diffuse ST segment elevation. But in STEMI, you see only in specific areas. The next thing, like you all have mentioned, is the saddle shape or a concave shape. ST elevation is evident in acute pericarditis, but it is not so most of the time in STEMI. It is like a straight away, you can see it. It's not a concave sort of a thing. The next thing, like you all have again mentioned, are the reciprocal changes. So here in ST elevation in myostemi, you see reciprocal changes relevant to that particular region of ischemia. But in acute pericarditis, it's a diffuse ST elevation. So this table again gives you now some important differences. Now PR segment depression, common in acute pericarditis, Q waves in MI, but may not be present always. STEMI, again, we discussed concave in pericarditis and reciprocal T changes. They are absent in pericarditis and T wave inversion. When it comes to T wave inversion, in STEMI, you usually see T wave inversion as can be associated as a reciprocal change or in most of the time as a reciprocal change. But in pericarditis, you can get T wave inversion, but not at the same time with the ST elevation. So I hope some of you might be knowing there are stages of ECG in acute pericarditis. So T wave inversion is more sort of a last stage change. So when you see T wave inversion, it is usually after ST segment comes to the baseline. So in acute pericarditis, you don't see T wave inversion together with ST segment elevation. So that you should remember. But in STEMI, you can see concurrently, like in this ECG. So these two changes you should definitely know because it's very common for you all to get this ECG, and to differentiate whether it's a STEMI or whether it's a pericarditis is a very important thing. The next thing, after identifying that this is a pericarditis ECG, the next thing that you all have to work out is to come to the management. So let's quickly have an overview of the acute pericarditis management. Now, this is from European Society of Cardiology. So I'm not going to explain what pericarditis is and everything. So this gives all of that. But let's start with this. So here you can see the pharmacotherapy for acute pericarditis. I hope all of you can see it clearly. So the mainstay of pharmacology therapy would be your NSAIDs or aspirin. So when you take NSAIDs, they are like the main pharmacological agents that are used for pericarditis. Even out of the NSAIDs, it's shown that ibuprofen has a safer profile. So it is like most of the time said as a safe drug when compared to other NSAIDs. But yes, other NSAIDs can also be used. Then you have aspirin, which is an NSAID that you can use. But it is said that aspirin is not favored over other NSAIDs in any cases other than when aspirin itself is indicated. So if a patient has indications for aspirin, then yes, you can use it. Then another drug would be your colchicine. again, you can use it when it is not responding to NSAIDs and all. Then that is like a basic overview of your management of acute pericarditis. All right. So here you have the drugs and the doses. So colchicine is not mandatory, but it is used when it is not responding to NSAID. But again, when you're using colchicine, it is used with NSAID. Okay. Then steroids, yes. One of you has asked about steroids. Yes, steroids, you can use it when the patient is not responding well. So poorly responding ones, you can use corticosteroids. Again, you can use the corticosteroid starting with a very small dose. So like a dose of this 0.2 to 0.5. And then that is also for cases which are not responding to NSAIDs. So in summary, when you take pericarditis management, NSAIDs are the cornerstone. If there's no much response, you are going for colchicine and steroids as later options. So even out of the NSAIDs, ibuprofen is a safer choice. Okay, keeping all of that in our mind, let's go through the answers that we have. We have indomethacin and NSAID. Morphine is there, which is an analgesic, and oxygen is there. Okay, so this morphine is given just to check whether you know this is not an ST elevation MI. Okay, so now this is out of option here. Now, out of the steroids, we have indomethacin only. So we have to go with that. So indomethacin is a good choice. Now, when it comes to oxygen, okay, now here see the saturation is 98%. So oxygen is not indicated in this case. So oxygen is not necessary here. You have to go with answer A, which is indomethacin. So indomethacin would be the correct answer here, like all of you have said. Okay, so let's see. There's a question. If the case is a child, can we use the NSAID? Yes, but the selection of NSAID, you should be careful. Ibuprofen, of course, you can use. But again, if it is like a neonate and all, then you have to be cautious. But in a child, you can use NSAID, especially ibuprofen. All right. Let's go to the next case. Next question. Foot image was given, which clearly showed multiple warts. They asked about the next best management. A, liquid nitrogen. B, cephalosporin. C, clotrimazole. D, salicylic acid. Okay, what do you think? All right, so I have answered all the questions from the previous question. All right. So here you have answers. A, liquid nitrogen. B, cephalosporin. C, clotrimazole. D, salicylic acid. Again, I can see that the answers are varied between answer A and D, which is liquid nitrogen and salicylic acid. Okay, so you can keep answering while I load the reference for this. Okay, so most of you think it's either liquid nitrogen or salicylic acid. Let's see. So this is a question testing your knowledge on cutaneous warts. Okay, so this they have given a picture of foot. So that is a plantar wart. In foot, if you have warts, it's a plantar wart. So they have asked the management. So it is a question testing your knowledge on treatment of common warts. Now here is your reference again. So this gives you the pathogenesis, differential diagnosis, and different pictures of the warts. So this is the wart, all right? So these are actually known as the cutaneous warts. So let's see what are the treatment options for these. So let me take to that. All right. Here. Now here you have the treatment options. Now different types and different etiologies are there for these warts. So most are self-limiting, okay? They usually resolve within 2 years, okay? But if the patient has any concerns, whether it has any problems limiting his daily living activities, aesthetic problems, now if actually he can't function with this wound in his foot. So if there are any issues, you have to actually just think of managing it aggressively or managing it instantly. Okay, so for initial presentation lesions, the drug that is usually used would be a salicylic acid. Okay, usually we are trying with best treated with like fresh treat, where here you can see with salicylic acid. So salicylic acid can be given as a gel, cream, or any other preparations. Okay, so we are giving salicylic acid as a local application, and with that we are trying to treat it initially. If it is not responding, or if it is very serious only, we are going with other treatment modalities, which you can see actually it's somewhere there. Other treatment modalities, which would be your liquid nitrogen and other therapeutic agents which you can use. Okay. So like nitrogen therapy, cryotherapy, laser therapy, and different other therapies are there, but that is not an initial sort of treatment for these sort of wards. So initially would be to give a salicylic acid local application. Now here they have not mentioned anything about whether this is an initial presentation or a recurrence, but since nothing is mentioned about recurrence, we can assume that this might be the initial presentation. Okay, so you have to go with salicylic acid, which is answer D. So let's go through the other answers. Liquid nitrogen, yes, you can give, but not as an initial treatment. This you are using if it is refractory to salicylic acid. Cephalosporin antibiotic is not indicated. Clotrimazole, again an azole, not indicated because it is not a fungal lesion as such. Then salicylic acid, yes, it is the initially recommended therapy. So as a local application, so answer D is the correct answer here. Okay? Okay. All right. Now, there's a question, liquid nitrogen has a better effect than salicylic? No, there are varied research evidences on that. There are a few who has like initially, yes, mentioned as liquid nitrogen has a better effect, but there are few studies which has shown salicylic acid salicylic acid will also give an equal effect. And that is number one. Number two would be, now you are not going to go for like very costly surgical sort of this liquid nitrogen sort of like costly therapies as an initial therapy. Initial presentation, you should treat with a salicylic acid, which is like when you take the side effect profile, adverse effect profile, and safety profile and everything, you are going to treat with salicylic acid as an initial therapy. After that, if it is refractory only, you are going to try with liquid nitrogen. Okay, and even if it is not responding, you are going to try with surgical options. Okay, so the next question, no more questions on that. All right. 607. Okay, the age is not clear. 8-year-old boy presents with unilateral red ear, which he got suddenly when he woke up in the morning. He had no other symptoms, no fever or pain. So, what is that? A. Erysipelas, B. Localized allergy, C. Anaphylaxis. So what do you think? Whether this is erysipelas, whether this is localized allergy or anaphylaxis? Okay, so most of you think this is not most, actually all of you think that this is localized allergy. Nobody thinks this is anaphylaxis or erysipelas. Okay, all right. So let's see. You have a 6 or 7-year-old boy coming with unilateral red ear, which he got suddenly when he woke up in the morning. So this is a sudden thing. He had no other symptoms, no fever or pain. Okay, no fever, no pain, no other symptoms. So when you go through the answers, you have erysipelas. So erysipelas is a skin lesion that you get. And so can anybody mention why is this not erysipelas? Any pointers to tell why is this not erysipelas? Can somebody mention? Yes, no fever, one cause. Yes, correct. Yes, painful, and it's usually the lower extremities. It's usually the lower extremities which are affected and no pain. Yes, correct. Yes, no other symptoms. Usually it's the limbs. Yes, very good. All of you have a very good idea on erysipelas. So this is not erysipelas because it's not painful, and also erysipelas usually involves lower limbs, and it's also localized. It also involves a localized area. No fever. So those features are against erysipelas here. So like all of you have said, now you have to differentiate between localized allergy and anaphylaxis. So anaphylaxis, why is this not anaphylaxis? Again, can somebody quickly mention? Why is this not anaphylaxis? No fever, yes. No low BP, yes. So in summary, like when you say anaphylaxis, when you have involvement of at least two systems out of the three systems. So the three systems are your skin, your cardiovascular system, and the respiratory system. So if you have involvement of the two systems out of the three, you say it's anaphylaxis. At least two of them. So now here you have only the skin involvement, but you don't have any other symptom. You don't have the involvement of respiratory or the cardiovascular. So this is not anaphylaxis. Okay, so low BP and everything that you have mentioned belong to either respiratory or cardiovascular. Okay, so that's why this is not anaphylaxis. But yes, this is a localized allergy, like all of you have said. Why? Because it involves the localized area, which is a unilateral one side red ear. Okay, and he has got this suddenly when he woke up in the morning. So this might be due to an insect bite or some sort of allergy to some sort of an insect or some sort of a thing. So this is a localized allergy, not anaphylaxis or not erysipelas. Okay, so that is the correct answer. Answer B, localized allergy. Okay. Next one. Young woman with 6 or 7 months amenorrhea and bilateral milky nipple discharge. CT done 2.4 to 3. The size is not sure. Okay. Centimeter mass found on pituitary gland. What is the next appropriate management? Take it as either 3 or 2.4, the size. What is the next appropriate management? Answer A, transsphenoidal surgery. Answer B, bromocriptine. Now see, in the last class, I think, when I discussed, I mentioned that pituitary tumors are a very common area that is being tested. So in the last class, we were discussing about pituitary adenomas. But here, it was not mentioned there whether it's a prolactinoma or what sort of a thing. So here, something similar, but in a different way. So please make sure that you have a very good understanding of the management of pituitary tumors. Okay, now what do you think we should do here? Go with a surgery or with bromocriptine? Okay, you can keep answering until I load the reference. Okay, so most of you think it should be answer B, which is bromocriptine. But some think we should go with answer A, which is transsphenoidal resection. Okay, so pituitary tumors, we were just thinking, we actually discussed in the last class as well. You have your macroadenomas and the microadenomas. So macroadenomas, the cutoff is 1 centimeter. So if they are larger than 1 centimeter, you call them macroadenoma. So here the size was either 2.4 or 3, but either way it is more than 1 centimeter. So this is a macroadenoma, pituitary macroadenoma. So you should know the management of pituitary macroadenoma. Now here the patient is coming with symptoms of prolactinoma, coming with milky nipple discharge, all those things suggestive of prolactinoma. So now we discussed this in the last class as well. Now most of the pituitary what we discussed in summary was most of the pituitary macroadenoma, we go with surgical management except prolactinomas. Now we discussed prolactin secreting macroadenoma. So prolactinomas, they usually respond to dopaminergic agonists. They have a remarkable response to that. Most frequently used one are your bromocriptine, cabergoline, those sort of things. But so prolactinomas, we usually start with the medical management of bromocriptine or cabergoline, which are your dopaminergic agonists, and they have a remarkable response to that. So that we discussed earlier as well. So, and we also discussed the other macroadenomas of the pituitary. Usually we go with surgical management. Now here again, 6 to 7 months of amenorrhea, bilateral milky nipple discharge, suggestive of prolactinoma, again a macroadenoma. So here the next appropriate management would be medical management, which would be your bromocriptine, answer B. But you will go with surgical management if the patient is having symptoms of like eye symptoms or the disturbances of his visual field, or if there are other symptoms which needs urgent intervention, yes, then you go ahead with the surgery. But here nothing that sort is there. So you are trying with medical management, hoping for the better response, which it has usually shown. Okay, so answer B is the correct one. All right, the next one. Scenario of a boy with constant sneezing and cold all year round and worse in the winter. Some other pointers to atopy present, asking for what to do to confirm the diagnosis. A, measure IgE. B, skin prick test to allergen. What should you do? We have a boy with constant sneezing and cold all year round and worse in winter. And some other pointers to atopy had been there, asking for what to do to confirm the diagnosis. IgE or skin prick test. Okay, so IgE will always be high. So answer was bromocriptine, yes, previously. Okay, so here again the answer is varied. Can somebody mention what is the now this boy is having constant sneezing and cold all year round and worse in the winter. Atopy was also there. So what is this case? What is this boy having? Can somebody mention? The diagnosis here? Allergic rhinitis, very good. Yes. So this is allergic rhinitis, like all of you have mentioned. So the point is here, he is having this constant atopy or constant allergy is there. Sorry, okay, constant allergy is there, but it is worse during the winter or winter seasons. And he has features of other atopy. So when the patient is having features of other atopy with these nasal symptoms, which are worse in the winter, that is clear-cut allergic rhinitis, okay? So again, this is a common area that is being tested. So again, allergic rhinitis, this is the reference that you have. So you have seasonal allergic rhinitis, so your hay fever in common terms, and perennial allergic rhinitis, different thing. The seasonal ones are the one that is present in this case. Then you have a functional classification, like whether it's severe or mild or moderate, intermittent or persistent. Likewise, you have a functional classification as well. And then you have the management. So you can go through this leisurely. So it is in general terms, this is like an allergy. And in seasonal one specifically, it is associated with different symptoms, the winter and all, okay? So now the diagnosis here is mainly by your skin prick test. So in skin prick test is the principal investigation that we do. So this will show that whether there is any atopy is present or whether any allergy is present. So it is done by pricking. I'm not going to explain it how it is done because I hope all of you must be knowing. And the positive result is a wheal more than 3 millimeter. Okay, but even it can be negative in some instances. So it is not always positive whenever you have allergic rhinitis. The other thing that you can do is to measure anti-IgE. So antibodies against IgE, that also you can do. But again, that needs a bit of more sophisticated laboratory investigations to measure anti-IgE. But this skin prick testing has been shown as a very good test, and it is usually practiced to confirm this allergic rhinitis and to show this atopy. So it is like mostly the recommended one. So the symptoms and all, because of time constraint, I'm not going to go deeply so that you can leisurely go through. So we have two, either skin prick test or your anti-IgE. Okay. Okay. So now here you have measure IgE. It's not the IgE that you are going to measure. It's anti-IgE, antibodies against IgE. You are not going to antibodies against IgE, anti-IgE or antibody IgE. So again IgE, yeah. So you can measure IgE and skin prick test to allergen, both are there. So skin prick test to allergen, sorry, is the like the recommended test that you are going to do here to confirm allergic rhinitis. Okay, so the answer would be answer B, which is skin prick test to allergen. So this is like the recommended test for confirmation of atopy. Okay, again, there's a question. IgE, anti-IgE over skin prick test? No. Usually you have to select skin prick test as the best investigation or the confirmatory investigation here, because it is the one which is usually practiced. Anti-IgE is not usually practiced as a confirmatory test for allergic rhinitis. So again, you have to select skin prick test. That question. Next question, serum tryptase investigation for anaphylaxis. Okay, so now serum tryptase, yes, it is an investigation for anaphylaxis, but remember, it is not an investigation for diagnosis of anaphylaxis. Anaphylaxis diagnosis is a clinical diagnosis. Tryptase is a retrospective test that you can do after you diagnose clinically anaphylaxis and manage it. Just to tell that case was anaphylaxis, for that you can use tryptase, but as a retrospective test. It is not a diagnostic test for anaphylaxis. Anaphylaxis always is a clinical diagnosis. Okay. All right, let's go to next question. Daughter found out her mother was browsing about euthanasia, asked what you should do. 1. Refer them for palliative care. 2. Ask her to go to court. C. Arrange an appointment with mother. 4. Discuss the matter with them. They mean both daughter and the mother. Again, this is an ethics question. Commonly tested area. It's an easy area, so let's discuss it quickly. Okay, most of you think we should arrange an appointment with the mother. Some of you think discuss the matter with them. Okay, so let's discuss this quickly because it's an easy one. Daughter found out her mother was browsing about euthanasia. Euthanasia, I hope all of you must be knowing, it's like a person is requesting the medical officer to kill her. So it's like killing herself with the help of the medical officer or some medical person. Ask what you should do. So answer 1, refer them for palliative care. Now it is actually not indicated. Why do you refer her for a palliative care? It's not indicated at all because they have not mentioned anything about the mother's condition. Ask her to go to court. No, you are not going to tell her to go to court because she was just browsing about euthanasia. So this might be herself just browsing about euthanasia to know, or sometimes this might be herself trying to know how it is done so that she can also undergo that. So the worry the daughter is having is that. So you are not going to ask her to go to court. Arrange an appointment with the mother, discuss the matter with them. So the difference between these two answers is whether you are going to discuss the matter with the mother first, or whether you are going to discuss the matter with both the mother and the daughter. So now put yourself into that situation and imagine, like, if it had been you, like, it would, the wiser or the logical decision would be first to check whether this is true, whether the mother is actually interested in euthanasia, is the first step that you should do before you take any other step. So for that, you are not going to discuss it together because Mother needs some privacy for her to discuss the problem that she's having. So the best thing you can do is first talk to the mother alone and check whether she's actually searching about euthanasia and whether she actually needs to undergo that or what is the problem that she's having. And then you can sort it out. But if you discuss it together with the daughter, the mother might not come up with the problem that she's actually having. So the wisest thing would be to arrange an appointment with the mother and not to discuss it together at this stage. Okay, so the answer would be answer 3, arrange an appointment with the mother. All right, so I hope that was clear and all of you had thought about that. What if mother is not our patient? All right, if mother is even now here, mother is not your patient, but mother becomes a patient in this case when because the mother has risk for her life here, because the daughter is worried about the risk the mother is having here for her life. So then you have to address it by talking to her. Okay, so that was addressed. All right, next one. Lady called emergency department threatening to commit suicide, and on arrival at the emergency, she's upset and requesting her former carer, who asked to be reassigned because she made inappropriate advances. She says he is in love with her and plans to marry her. However, after 4 hours wait in the ER for review, she changes her mind and says she wants to go for swimming lesson. What is at play here? Is it erotomania or manipulation? This lady has called the emergency, threatening to commit suicide. On arrival at the emergency, she is upset and requesting for her former carer who asked to be reassigned. So she's asking for the former carer or former doctor. Now, former doctor has been reassigned because she has made inappropriate advances at the former doctor. But she says that former doctor is in love with her and the doctor plans to marry her. After some time, she changes her mind and wants to go for swimming. What do you think here? What is the psychopathology, or what is the phenomena that is being described here? Okay, all of you think it is answer 1, erotomania. Yes, very good. That is the play here. Now, erotomania, what is erotomania? In erotomania, the person believes that someone else is in love with her. Now, think of this lady. She thinks that the doctor is in love with her. Oh, and the doctor plans to marry her, and that is a delusion that she's having. She thinks so. She firmly believes that. So that's a delusion, and she thinks that person is in love with her. In erotomania, it's usually the person that they think in love with them are usually of a higher standard than them, but it's not always. Usually it's like that. Now here this lady, she thinks the doctor is in love with her. Most of the time this is seen when people think some actor or a famous actress is in love with him or her. There are like such reports also in the past. Okay, so that is erotomania. Now this is a clear-cut case. Now she has called the emergency threatening to commit suicide. Why? Then she would be brought to the emergency. She is doing this to come and see that doctor. And now he is telling that Kiara, he was in love and she plans to marry her, but she has not been given that Kiara, so she changes her mind and wants to go for swimming lesson or some sort of a thing. Okay, so here this is erotomania. Why is this not manipulation? Now in manipulation, they try to use something to get something done. So if she wants to get some, maybe a drug, maybe let's assume she wants to get a painkiller, morphine or some sort of a drug, then she will tell, if you don't give me this, I will commit suicide or I will kill this person. So that is manipulation. They will do something to get something done. So here nothing such sort is there. Here, this is simply an erotomania. Okay, I hope it was clear why this is not manipulation and why erotomania. For those who thought this is manipulation, if it's not clear, just let me know. I will explain it again. All right. Next question. Patient with confusion and hyponatremia, what is the management? A, normal saline. B, 3% saline. Okay. Now it is lacking another management. Take answer C as nothing. You are not going to do anything here. Okay. Just for the sake of discussion, I am adding this. Okay. Because sometimes you will not always get all the answers correct. Sometimes there won't be a correct answer. So I'm adding this answer C as nothing. You're not going to do anything. You're going to give normal saline. You're going to give 3% saline. You're not going to do anything. Okay, what do you do? This is hyponatremia management. Okay, so you all are, the answers are varied between 3% saline and normal saline. And nothing. Nobody thinks we shouldn't do anything. You can keep on answering while I load this. Answer A, B, A, B, B. Shouldn't the 3% be a bolus? Okay, let's see. There's a question. All right. Okay. Okay, so this is the reference. Now here, this is your NSW emergency management thing. Now this actually has a very good reference for all the emergencies. Now RSAGP or your RSAGP reference, that is like a GP one, that is not for usually for your emergency management. That is for your baseline management. Now for emergencies, this would be a very good tool because here you can see like different topics of emergencies are here with a nice overview of how you should manage them. So I would recommend this as a very good source. But anyway, you can go through this leisurely. Now here hyponatremia. See, it gives a nice overview. So like what are the summaries? Then you have a background. Then you have the different causes. Assessment is there. And the treatment. Now see, investigation, what you should do, and the treatment. So this is like a brief summary. That's why I'm highly recommending this, because it's not too much. Because with the limited time that you all have, the reference that you are going through should be something which is easily accessible and it should be easy to scan through. So this is something like that. Okay, so let's go through the hyponatremia management. Now, the most important thing, okay, before we, okay, anyway, I should have asked this question before I display this. All right, somebody wants me to zoom in, all right. I should ask this question before I show this flowchart, but anyway. So the most important thing that comes when to management of hyponatremia, you have to ask two questions. The first question would be whether the patient is symptomatic. So the management completely changes if the patient is symptomatic. The symptom being either a seizure or encephalopathy. Encephalopathy means altered consciousness, any sort of altered consciousness. So if the patient is symptomatic, your management is completely different. If the patient is not symptomatic, the management is completely different. So the first thing is whether the patient is symptomatic or not. If the patient is symptomatic, yes, then it is a medical emergency, okay? So you have to give 3% saline as a bolus. Somebody has asked it in the question box. You have to give it as a bolus, okay? Because it is, you have to give it as a bolus, and then you have to monitor. If it is a seizure, you have to go for seizure control. If it is encephalopathy, you have to then check whether the consciousness is recovering, okay? And also you should remember, if it is not a seizure, if it is seizure, you have to actively control it. But if not, you have to achieve a correction of about 10 millimole per liter in about 24 hours. Not overcorrect. Can somebody mention why shouldn't we overcorrect this? Why shouldn't we like rapidly overcorrect this hyponatremia? Can somebody mention the reason for that? Yes, pontine demyelination, the risk of pontine demyelination. Very good. Okay, so if there are no symptoms, I told you hyponatremia, you ask main two questions. One is whether there are symptoms. If there are no symptoms, the next question that you have to ask is the volume status. Okay, you have to assess the hydration. Now, if there are no symptoms, remember, you are not going to correct it with 3% saline because it is harmful. if it is symptomatic only, you are going with 3% saline. Okay. Now, if it is not symptomatic, you are checking whether it is euvolemic or hypo. You are actually checking whether it's hypovolemic or euvolemic. If it is or hypovolemic, if it is eu or hypovolemic, the management would be fluid restriction. Okay. If it is hypovolemic, then you are giving IV fluids. Now, in that case, you are going with normal saline. One answer was normal saline in our question that you give if it is not symptomatic and hypovolemic. Okay, then you are going to monitor. Again, you have a serum correction level here for that. Okay, this is like a summary of hyponatremia management. All right, so let's go back to our question. We have patient with confusion. Okay, now we discussed we have to ask two questions. First question was whether it's symptomatic. Now he passes our first question. He has confusion. So our management would be correcting this. So we have to give 3% saline as a bolus. Okay, so answer would be answer B, which is 3% saline. All right. Okay. Correct. Let's go on to the next question. Cord prolapse case, head was 2 cm above ischial spine. Patient was 8 cm dilated. Theatre busy. What to do in the meantime? A. Replace cord. B. Inflate bladder. C. Ask mother to push. D. Assisted delivery. E. Put patient in lithotomy. Okay, what do you think? Again, cord prolapse. Now, I hope all of you have seen this being repeated several times in different cases. So, cord prolapse case, you have head was 2 cm above ischial spine. Patient was 8 cm dilated. Theatre is busy. Okay. Okay, there's a question, ma'am. Can you please explain the erotomania question again? Okay, so I'll explain it after this. Okay, so nice discussion is going on in the chat box. I was just observing. So some of you are for answer B, which is inflating the bladder. Some think we should do answer A, which is replacing the cord. Okay, and assisted delivery, some think we should go for assisted delivery. Okay, so let's see. All right. So now in cord, this is a cord prolapse case. Head was 2 cm above. So the station is -2. Okay, station being -2, so it's way up. Patient was 8 cm dilated. Theatre is busy. Okay, what to do in the meantime? So in a cord prolapse case, your priority would be to deliver the baby urgently. Okay, so that is like the main principle or key principle of cord prolapse management. All right, so let's see whether we have any option to deliver the baby urgently. So let's see, we have replaced the cord, inflate the bladder, ask mother to push. Yes, this is an option to deliver. Assisted delivery, this is an option to deliver. Put the patient in lithotomy, let's keep it. Okay, so ask the mother to push. Now, we are not going to ask the mother to push because the cord has already prolapsed. You are not going to put another pressure on the cord and like compress it again. So this is not encouraged here. This is wrong. And the patient is not in active labor. You don't see any the patient has the cervical dilatation. Yeah, sorry. But here you are not going to ask her to push because already you are having a cord prolapse. Then assisted delivery. There were some who thought we should go for assisted delivery. Why not assisted delivery? Why can't you go for assisted delivery here? Can somebody mention? Why? Yes, the os is 8 centimeter. Very good. Os is 8 centimeter here. You should have the os fully dilated to go for assisted delivery. So that is not an answer here. Okay, that is wrong. Answer D is wrong because one requirement for you to go for assisted delivery would be having a fully dilated os or a 10 centimeter os. Now it's only 8 centimeter. You can't do assisted delivery with that. So that is wrong. Okay, then go through the other options, replace the cord, inflate the bladder, put the patient in lithotomy. Now you need the knowledge on the management of cord prolapse, okay? So let me just have it in a brief way. The first thing would, now this is not, okay, so they have mentioned as manually elevate the presenting part. Now that you are not going to do first, okay? Just keep it aside. This means you are trying to push the head of the baby up to the presenting part. If it is head, you are going to push it up. If it is buttocks, you're going to push it up so that it's not compressing the cord. But just don't do it at the first. This shows it as the first, but just forget it. The first thing would be to positioning the woman. So you have to use this knee chest position, or you can use the exaggerated seams position, but the commonly one is the knee chest position. Okay. Then you have to fill the bladder. The main principle of cord prolapse management is to prevent the cord getting compressed. Okay, understand that. So you are going to try to do everything possible to prevent it from compressed. In the meanwhile, you are trying to deliver the baby soon. Now here, bladder filling, what you are going to do is, by filling the bladder, you are pushing the baby up, or you are pushing the presenting part up so that it is not compressing the cord. Okay, then, so that is like the main thing. You are putting the knee chest position and you are filling the bladder. Now you have the rest of the things here, the main principles I have mentioned. Now replacing the cord. Replacing the cord. Now, what do others say about that? Those who didn't think we shouldn't we shouldn't do replacing the cord. Can somebody mention why shouldn't we replace the cord? What do you think about that? Okay, can somebody mention why, how replace, what about replacing the cord? Should you do it or you shouldn't? Yes. Here the replacing mean putting the cord inside. Now cord prolapse mean cord has come out, no? So you are going to put it inside again to the uterus. Should you do it or not? Okay, now the thing is, alright, there's a question about how filling the bladder help quick delivery. It will delay labor. Okay, I will address it later. Now I will first discuss about this replacing the cord. Now replacing the cord is not an option, not a very good option here. Why? Because you should not handle the cord a lot. When you handle the cord, it will go into spasm. You are not going to put the cord back into the cervix or uterus, because if you handle the cord, it will go into spasm and it will complicate the things. So you are not going to replace the cord. Yes, but if the cord is out, you are going to gently cover it with the gauze and you can put it inside the vagina, but with a minimal handling. It's not something that you are going to manage the cord prolapse. Okay, that is, you can with a sterile gauze or something, you can wrap it and put it inside the vagina with minimal handling. You are not going to replace it inside, because when you handle it, it will go into spasm. So that is out of the option. Then putting the patient in lithotomy wrong, you are going to put it in the knee chest position. Now there was a question about how the inflating the bladder will help the labor. Okay, now the thing is, the first principle of cord prolapse management is you have to deliver immediately. Okay, so now here, when you are delivering immediately, you have to check whether the mother is in labor. Like suppose if the os is 10 centimeter dilated and the baby is almost coming down, yes, then you don't need to go for anything. You can quickly do an assisted delivery and take the baby out. But here, the patient is only 8 centimeter dilated. See, the station is -2. The baby has a long way to go. Okay, and you can't allow this to take place naturally, or you can't do this, allow this to happen slowly, because then the immediate delivery, you can't deliver immediately. Here, the immediate delivery option would be going for a cesarean section or a surgical option, because you can't go for natural labor here with this condition. But see, for you to go for cesarean section, the theater is busy. Okay, so theater is busy, and so once it is available, or unless it is as soon as it is available, you are going to go for cesarean section. But until that, you have to take some precautions or some maneuvers to prevent the damage, further damage. So until you, now even if the theatre is available, until you have to transport the patient from the ward to the theatre. So until that, you have to take some measures to prevent the cord getting compressed. So the some measure that you can do to prevent the cord getting compressed would be inflating the bladder. If you inflate the bladder, the presenting part will go up so that the cord will not get compressed. Then you can take the patient to the theatre and do the urgent delivery with the cesarean section. So this is not to urgently deliver, but to prevent the compression of the cord. Okay. So for the person who asked the question, I hope it is clear now. If it's not clear, just let me know. I will explain it again. Okay. Okay. All right. Next one. Parents worried about 4 months old baby crying all night and not sleeping at all. Baby was born in normal term delivery. Baby having exclusive breastfeeding. What to do next? 1. Add additional extra meal at night. 2. Try to get more information about the baby. 3. Reassure the parents that it's normal. Sleep hygiene maintained. Okay, again, how inflating bladder help the process? Okay. Okay, if it was not clear, just let me know. If inflating bladder means you are putting a catheter, yes, and you are inflating the bladder so that you know that when you take the anatomy, the uterus is in front, the bladder is in front of the uterus. So when you inflate the bladder, the baby's presenting part will go up, preventing the compression of the cord. Okay. So I hope it's clear. If it's not clear, just let me know. About the replacing the cord, no, you should not replace the cord. You should not handle the cord. Uh, you should put the mother in the niches position and inflate the bladder. You can cover the cord with a sterile gauze and put it inside the vagina. Just because if not, it will be hanging around and it will get like infected and all. That's it. Okay. Now here, parents worried about 4 months old baby. 4 months old baby crying all night and not sleeping at all. Baby was born normal term delivery. Baby having exclusive breastfeeding. What to do next? Okay, now here a 4-month-old baby crying all night seems like a common phenomenon. It's like a small baby. They cry all night for various reasons. Okay, so what are you going to do if the mother comes with this concern? This could be a normal phenomenon, or if it would be because of the baby is hungry or some sort of a thing. Add additional extra meal at night, that to address the hunger, because the baby might be hungry, so he or she is crying without sleeping. So this is to address the hunger. Try to get more information about the baby. Reassure the parents that it's normal. This could be normal. Sleep hygiene maintaining for a 4 month, it's very difficult, but yes, you can try. So here you can't, I think somebody's microphone is not muted. Can that person please mute yourself? Okay, so here this could be normal or this could be due to some other pathology as well. This baby might be ill. This baby might be having some other problem that is preventing him from sleeping. This could be other illness. Nothing about his physical condition, physical examination or anything is mentioned here. So the next thing that you should do is to try to get more information about the baby. Okay, you are not going to add additional meat without knowing anything, any further information. Sometimes the baby might be having a good meal at night. Reassure the parents that it's normal. You are not going to do this as a first step. You have to exclude the other problems and then you are going to do that. Sleep hygiene maintain, not very easy with a 4-month-old, but yes, if you are trying that, you have to exclude other pathologies. So the correct answer here would be answer 2, which is try to get more information about the baby. Okay. Okay. All right, again, colic, infantile colic, reassure. Yes, if it's infantile colic, you can reassure, but there are other steps you can take to like prevent it. You can advise the mother on that as well. Infantile colic is between 2 weeks to 4 months, isn't it? It can extend after that as well. Okay. All right. So you don't have any information about the baby here. If it is an infantile colic, the pattern of cry, the baby will usually cry by pulling his legs towards the abdomen. So there's just like a specific way of crying, and it is will be a cry constantly for about hours without settling. So this might be an infantile colic. This might be due to hunger. This might be due to some other pathology. We don't know anything. We need more information about the baby. Baby's growth, whether the baby's urine output, whether the baby is urinating well. So to see whether the baby's activities are good or not. So we need those details to see whether this is a normal thing or whether there's any pathology involved. Okay. All right. I hope that was clear. Okay, so before we move on to the next question, let's take the break now for, I think, for 5 minutes. We'll break up for 5 minutes and then we'll meet again to continue with the rest of the questions. Okay, shall we start? Are you all back from the break? Okay, all right. So let's start. Okay, baby's picture with a scabies rash was given. What to give next? 1 permethrin cream, 2 corticosteroid cream, 2 mupirocin cream. Okay, so most of you think it's answer 1. Okay, you can vote for that until I load the difference. So, reference. So scabies, again, another uh, commonly tested area in dermatology. You should know how to differentiate scabies. Like scabies rash can be given as a picture for you to identify. And the management could be asked. Okay, so now scabies again. Now this is a baby with scabies. Okay, so again you need to like know this is a pediatric scabies case. Okay, now this is your reference. Okay, let me zoom it. Okay, so your diagnosis is usually a clinical diagnosis. You can see the scabies rash and this characteristic rabies burrows. Okay, usually it is the distribution is different in infants and children. So that I'm not going to discuss in detail. Okay, so the management mainstay is your topical antiparasitic, which is your permethrin cream. Okay, there's a way of applying that for different types of scabies. For adults and children over 2 years, you have a different way of applying. You are applying it to the whole body, not to the face. Infants and children less than 2 years, you are including neck, face, ears, and scalp. That is because of the distribution of scabies. Okay, so that you can leisurely read. Now, how much to apply and everything is there. Okay, so what you have to know is the mainstay of management of scabies would be your permethrin. All right. Now here as answers you have permethrin. Yes, correct. So it should be your answer. Answer 1. Corticosteroid, and you have this mupirocin. Can somebody mention for what do you use mupirocin? Because we discussed it in a recent record. That's why I'm just asking to remind. Mupirocin, for what are you using mupirocin? Yes, very good. For impetigo. That is for a simple impetigo, not a systemic one. Okay. Next one. A lady came to ED with type 1 diabetes mellitus history and got unconscious in the morning for an hour. After all necessary management, she felt better, regained consciousness. She was worried because every day she had to drive her daughter to school. What will be the best advice for her regarding driving during discharge of this patient? 1. Can't drive for next 6 weeks. 2. Will not be allowed to drive in the future. 3. Referral to driver licensing authority. So what you should do, you have a lady coming to ED with type 1 diabetes mellitus and got unconscious in the morning for an hour. Then all necessary management has been done and then she has been better and regained consciousness. She has to drive her daughter to school and she is asking whether she can drive or not, like the recommendation. What do you think? So can somebody mention what has been her clinical presentation? Can you guess, like they have mentioned only unconscious. Yes, commonly it would be a hypoglycemia. Why? There is a concern about DKA also. Why not? This is DKA and why yes, in DKA, yes, you can get unconsciousness if it is very severe. Okay, so why is this hypoglycemia and not a DKA? Yes. Okay. So the point is for you to think that this is hypoglycemia is one thing. This is a type 1 diabetes mellitus. And so she might be jolly well on insulin, and this has caused to, and in the morning she has developed this unconsciousness. Because of that, you can think she might be hypoglycemic now. And the insulin is very well linked to hypoglycemia. So this might be a case of hypoglycemia. But in the original exam, you will be given like whether this is hypo or hyper, you will have enough pointers, because even DKA can present like this. The next thing that makes you think that this is hypoglycemia is, if it is DKA, they would have given other symptoms like vomiting, predominantly vomiting. You have vomiting, which is a severe abdominal pain with vomiting, is a very classical feature of DKA. So they would have given that. The patient presented with abdominal pain and vomiting, initially had this, and then she became unconscious if it is severe. Okay, but in the original exam, this will not be that much ambiguous. They would have given at least the management. So after giving glucose, she felt okay. Or after giving after managing with IV fluid, she became all right. Some sort of a thing would have been given. But here we are thinking of hypoglycemia because it is a type 1 diabetes mellitus, and they have not mentioned any other symptoms of a DKA here. So assuming that this is hypoglycemia, let's look at the question. So now this tests your knowledge on driving recommendations. Now for that, you need to know, you have a reference for that. That would be your Ostrott's driving recommendation. So this is that, assessing fitness to drive. I have put the link in the note that I will be sending you all, but you can just type it in the Google and download it as well. So this is the assessing fitness to drive. Okay, so this gives you like for different condition, for how long they can drive and for how long they cannot drive, etc., etc. Okay, now so we have diabetes mellitus here. So you can see, let me zoom it. You can see different conditions here. For that, you have driving recommendation. Now for diabetes mellitus, now here this patient has had a hypoglycemic event. Now this hypoglycemic event is a severe one or major hypoglycemic event. We call it a major hypoglycemic event because the patient has needed the help of another person to recover from this hypoglycemic effect. So that's why it's a major hypoglycemic effect. So if a severe hypoglycemic effect occurs, the person should not drive for a significant period. The minimum period would be generally 6 weeks. Okay, why? It is because it takes that time for the pattern of glucose control and any temporarily impaired hypoglycemic awareness to resolve. So this is the recommendation. So for minimum, she should stay without driving for 6 weeks. Okay, so that you should tell the patient when you are discharging the patient. Now, while we are in this, let me show you the next thing which you should focus. That would be this table, which gives you like how to get the different standards for private vehicle and commercial vehicle for patients who are on diabetes controlled on diet, on insulin, or on medical drugs. So this you can leisurely go through that later. Okay. All right. So in our question, you should tell her that she can't drive for next 6 weeks because that is at least minimum. After that, you have several criteria for her to drive again after that. So the correct answer here would be can't drive for 6 weeks. Okay, you can't say that she will not be allowed to drive in the future because you have to assess her later. You don't need to refer her at this stage. Okay, so the answer would be answer 1, which is can't drive for next 6 weeks. Hope it was clear. All right, next one. 26-year-old G2P naught came to ED at 40 weeks gestation with sudden leakage of clear fluid. This is not fungal, sorry. Fundal height 41 weeks. Fetal heart rate 155. Blood pressure 120/70. Vaginal examination. Cervix 2.5 centimeter elongated but closed. Station was -2. What to do next? 1. Vaginal prostaglandin clean. 2. Amniotomy. 3. Watchful waiting. You have a 26-year-old G2P naught, 40 weeks of gestation. Sudden leakage of clear fluid. 1. Vaginal prostaglandin clean. 2. amniotomy. 3. watchful waiting. You have a 26-year-old G2P naught, 40 weeks of gestation. Sudden leakage of clear fluid. 1. Vaginal prostaglandin clean. 2. amniotomy. 3. watchful waiting. Fundal height 41, fetal heart rate 155, blood pressure 120/70, cervix 2.5, elongated and closed. Station -2. Okay, so the dilemma is between answer 1 and 3. I can see vaginal prostaglandin and watchful waiting. Okay, so let's see. You have a lot of information in this question. So let's go through them one by one. So you have a 26-year-old G2P note. She's coming at 40 weeks of gestation. Whenever you have a question relevant to labor or pregnant woman coming in labor or labor management, always focus on the POA of the mother. Why? Because that will decide whether you have to deliver the baby urgently or whether you have to take some measure to do things urgently or fastly, or whether you can have some time to wait, especially in preeclampsia sort of a thing. In emergencies, the PO is very, very important. So here 40 weeks. Now it's almost sorry, it is a 40 weeks gestation. So you have to focus on this. This is not 37 or 38. She's coming with sudden leakage of clear fluid. So this is a rupture of membrane. Sudden leakage of clear fluid means they're trying to tell her membranes have ruptured. Okay. Fundal height is 41 weeks. Why? What are they trying to tell that? They are telling you that this is not a IUGR or this is not a macrosomic baby. The fundal height is matching for the gestation. Fetal heart rate is 155. This tells you the baby is all right. Okay, so baby is not compromised. There's no bradycardia. Mother's blood pressure is 120/70. This tells you the mother is hemodynamically stable. Vaginal examination. The next most important thing in labor management would be your cervix. Now, you see it is 2.5 centimeter elongated. So it's not dilated here. It's the cervical length is given. Now, I hope all of you paid attention to this. This is not the cervical dilatation. This is the cervical length which has been given, 2.5 centimeter. It is 2.5 centimeter means it's not dilated, right? And see, the os is closed. Cervix is not open, it's closed. Station was -2. The baby is way up. So what to do next? Now here, you have a case of rupture of membranes. Now, in a case of rupture of membranes, what is your worry? Your worry would be the risk of infection. You can't keep this mother for a long time because there's a risk of infection because the membranes have already ruptured. But that doesn't mean you have to go and do a cesarean section and take the baby out. Now it's it. That doesn't mean that. Okay. So now here, when you go through the answers, here you have vaginal prostaglandin cream, that is for cervical ripening, for cervical induction. You have amniotomy. Amniotomy is not necessary here. Why? Because the membranes have already ruptured. Watchful waiting. So you have to decide whether you are going to wait some time for this to progress or whether you are going to give vaginal prostaglandin cream. Okay. Now, when you look at this case, you can see, can somebody mention whether there are signs of this labor progressing or not? What do you think? Will this labor progress or not? When you go through the case, will it progress naturally or not? Can somebody give an idea on that? Or are there things to say that it will not progress if you don't intervene? Yes, very good. It's not progressing well, right? Why? Because there are enough pointers to tell you this labor is not progressing well. Why? Because the membranes have ruptured, but still see the os is closed. And its length is still 2.5. There are no signs of the cervix dilatation. So here you can see the problem is with the cervical ripening. The cervix has not ripened. It has not dilated. It has not opened. That's why this labor is not progressing. So if you don't intervene with that, it will not progress naturally. There are no contraction, no labor pains to the mother, nothing is there. Okay, so if you watchfully wait, it's high chance that it will take a lot of time or lot of days for this to, it will not progress naturally. It will put the mother at risk for infection. Why? Because the membranes have already ruptured. There's a risk of chorioamnionitis. So what you're going to do is you're not going to wait here. You are going to help by giving a prostaglandin cream. What will it do? It will ripen the cervix. The cervix will open up and the baby, there's a chance for the labor to progress. So here the correct answer would be answer 1. You are going to give a vaginal prostaglandin cream. Okay, so that would be the correct answer. Okay, I hope. All right. I hope it was clear. Now here, this sort of a questions, in labor questions, specifically, you have to like work out with the POA. You have to think about the POA. Now, if this is a 40 weeks, you can't keep this for a long time also. And even with these 40 weeks, still the cervix has not ripened or matured. So it's high chance this labor will not progress. Okay, so this is like labor questions are always things for you to work out and use your mind and to come to an answer. So you have to do a lot of labor questions to make your mind used to that. If membrane rupture, can we put prostaglandin? Yes, you can. You can give, you are using a prostaglandin cream here. Okay, reference. Now the reference is just the labor management. You can read the labor management and then you have to do a lot of questions to focus, learn how to work out. Okay, I hope that was clear. When you do a lot of questions, you will understand. All right, next one. A lady, 23 years, 36 weeks pregnant. Again a labor one. Called to ED because she's feeling her baby today moving less than average. She was otherwise fine, no associated abdominal finding in her pregnancy profile. She also have a regular appointment with GP tomorrow morning. What will be the best advice? Increase fluid intake, stay home, come tomorrow for checkup. 2, come now for review a CTG for baby. 3, admit to the hospital now. If C-section was in option, still we will go with prostaglandin. Yes. Yes. Again, you are going with prostaglandin because if it is, even with that, if it is not progressing only, you are going for C-section. Okay, I hope I addressed all the questions there. Okay, now here, see, you have again another labor one. Now, these labor questions, I'm again telling, do as much as possible because then only you will, not this one, actually the stations and with the cervix and the ostenom, then only you will practice them. Because they are not straight away theory, you have to think and work out. All right, a lady 23 years, now she's 36 weeks pregnant, okay? Called to ED because she's feeling her baby today moving less than average. So the mother feels usually the baby's movements. Now she feels the baby's not moving as same. She was otherwise fine. No associated abdominal findings in her pregnancy profile as well. Now she has a GP appointment tomorrow morning. So this is asking you whether what are you going to do now. Now, number 1, this tells you that you are going to review her tomorrow. Increase the fluid intake, stay home, come tomorrow for checkup. Come now for a review CTG for the baby. So they are checking what is your plan, whether you are going to review her a CTG today or you are going to see her tomorrow with these measures. Admit to the hospital now. Okay, now here the mother is feeling the baby is not moving well. So the mother has a concern. You have to address that because a mother will be usually used to the baby's movement patterns. Mother will be usually used to the baby's movement patterns. Specifically with this POA 36. If this is an early POA, well, the mother might not be very much used. Now, by 36 weeks, the baby has a pattern of movement which mother is usually used. So, if a mother is sensing something is not normal, you should always address that because it's most of the time that concern becomes legible. Okay, so here she is feeling she has this concern. So if the baby is not moving well means you have to address this issue. If you wait till tomorrow with all these measures, sometimes the baby might go into an IUD. So you can't give this much of time for this for the review of this baby. She might be fine, but the baby, she has this concern. So you're not going to tell her to come tomorrow with these measures. You are going to do a CTG now and exclude any problem. Okay. So that would be the best measure you are going to do. So answer 2. You don't need to admit her unless the CTG is pathological. So answer would be answer 2. Next one. Patient's mom wanted to do sterilization for her mentally disabled 18 years daughter. What would you advise her? It's illegal to do at her age. 2. Go to local mental health tribunal. 3. Report to local social service. What are you going to do? Again, ethics. Okay, somebody's asking the answer for the last question. Answer was answer 2. Come now for a review for a CTG. Okay. I'm highlighting the answer, okay? So that would be the answer. Now here the patient's mom wanted to do sterilization for her mentally disabled 18 years old daughter. The daughter is mentally disabled, so the mom is worried why the baby, whether the daughter might, because she's mentally disabled, some person might use it as an advantage, have a relationship with her, and she might get pregnant. So the mother is worried, so she wants the doctor to get her to have a sterilization. So what are you going to do? Now this way, daughter is mentally disabled, so she can't give consent. Now mother is telling to sterilize her. Daughter is 18 years. Now the answers, it's illegal to do at her age. That's wrong. There's no age for sterilization as such. If the patient or if the person is giving consent, you can go with that. Next one, go to mental health tribunal. Okay, that would be the correct answer actually. Why? Here the daughter cannot give consent. Mother wants her to get sterilized for legible reasons, for good reasons. But you can't go with mother's wish for this. So you have to get some legal opinion on this. So this should be taken to the local mental health tribunal. There this case would be given and you will get a decision there. You can't decide in this case. Report to local social service, that is wrong because social service cannot do anything here. This is not anything relevant to the social problem. Here the problem is with the consent and the legal issue. So the correct answer should be answer 2, which is go to local mental health tribunal. Okay, answer 2. Okay, next question. Again, 10 years lady came with migraine with aura. She doesn't want to be pregnant now due to her business purposes. Want a baby later, asking for contraception. What to give? Progesterone only pill, COCP, copper, IUCD. Okay, if somebody thinks that there are multiple answers, or if you think that you need more information, you can mention that as well. Huh? Okay, again, this is a question on contraception. So the problem is, I can see the problem of y'all is between 1 and 3. There is the answer for answer 2 as well, OCP. Okay, so when you have a now contraception, again a common topic. I'm not going to repeat it because I have told it several times. Now, this is your reference for contraception. That would be your medical eligibility criteria. I have shown this to you in a previous review as well. That is your UK MECO medical eligibility criteria. Okay. Now, when it comes to migraine, now where is it? Okay, so here you have with aura and without aura. So your copper IUCD, yes, you can use, no problem. Now this patient is having with aura. So copper IUCD you can use. Now let me show you your combined hormonal contraceptive. It is contraindicated. Actually, you can't use it. Progesterone only pills you can use actually. You can use, but with condition where you can use it, the advantages generally outweigh the risk. It belongs to category 2 actually. Progesterone only. Now it is not clearly mentioned here. You can see it. Combined oral contraceptives you can't use. Why? Because with the migraine, estrogen you can't use. Okay. Estrogen you can't use. The best thing would be copper IUCD. You can use it without any problem. Even progesterone only pill you can use. So I saw somebody has also mentioned like that. You both answer 1 and answer 3 are correct. Combined oral contraceptive you can't use because of estrogen. Okay. So how do you decide between 1 and 3? For that, you need either, not either, actually you need the duration that she doesn't want to be pregnant. Now they have not told whether she wants to get pregnant soon or later. Now copper IUCD, it will provide protection for years. Progesterone only pill, if you stop it, you will regain the pregnancy again. So if she wants to delay this for a short period, yes, progesterone only pill would be a better option. But if she wants this for a longer period, then copper IUCD would be the better option. So this question is lacking information. So you need the duration for which she needs to get pregnant. This later, she doesn't want to be pregnant now will not. This later will not imply how often, how later. So the duration is necessary. But if they have asked what is the best contraception for her, then again you have to select copper IUCD because copper IUCD has shown the Pearl index is high. It has shown best efficacy than progesterone only pill. So if this question had been what is the best contraception for her, then you have to go with copper IUCD. Or if they have mentioned the duration, with that you can select if it is for only for a shorter period, you can select progesterone only pill. So with this question, you have 2 answers because it's lacking information. Both progesterone only pill and copper IUCD are correct. Okay. Okay, all right. Does the age matter? Age, of course, if it is an adult, is not of a matter. But if she has with advancing age, some might have comorbidities. If it is a 60-year-old, she might have other comorbidities which you have to think when you are prescribing contraception. For that matter, age is important. But age alone is not important to decide the method of contraception. The age associated other factors are important. Okay. Next one. 16 years old, works in a street joint food, came with recurrent diarrhea. What is the management? 1, isolate her from family members. 2, be advise don't go to work for 2 weeks. 3, advise washing hands regularly. Avoid using public toilets. If duration not mentioned, okay, for an earlier one, if duration is not mentioned, if duration is not mentioned, they will give any other clue to come to an answer. It might be what is the best contraception, some sort of a thing. Or this might mention she doesn't prefer to have any invasive procedures. Then you are going for progesterone. Or the question might have she doesn't want to she has a busy schedule, she doesn't want to take any pills because she might forget, then you are going for copper IUCD. Likewise, there will be a leading point in the question for you to select from both of that. Okay, now this is an easy one. All of you have mentioned answer C, which is very correct. Here she is 16-year-old. He is having recurrent diarrhea. So he's coming with different episodes of diarrhea because she is working in a street food joint. So what is important would be hand hygiene, most important thing. Isolate her from family members. This is not necessary because this is not an infectious or contagious disease. Advice to don't go for work for 2 weeks, that is not necessary. This is a diarrhea, not something else, not a contagious disease. Avoid using public toilets. You can't tell that because sometimes you might have to use it, especially when he is working in a street food joint. He might need to access it also. Then advise washing hands regularly. Yes, that is the correct thing, and that is the most logical thing that he can do. Hand hygiene is the most important thing to prevent recurrent diarrhea. So answer C is the correct answer. Next one, women with multiple joint pain and scaly rash over elbows. What is the diagnosis? A, rheumatoid arthritis. B, SLE. C, psoriasis. Okay, again, this is also very easy. Arthritis, again a common area. Okay, so this woman is coming with multiple joint pain and scaly rash over elbows. Whenever you hear the word scaly rash, the most important thing that should ring a bell in your head would be psoriasis. Scaly rash, psoriasis, like go hand in hand, okay? Now, when you have rheumatoid arthritis, you don't get a scaly rash over elbows in rheumatoid arthritis. So, rheumatoid arthritis is out here. What about SLE? Yes, you can get skin manifestation in SLE. You can get rashes in SLE, but it's not a scaly rash. And it's usually the commonest rash that you get in SLE would be your butterfly rashes that you get in your cheeks. It's not a scaly rash. So SLE is out. Psoriasis, yes, correct. It is the psoriatic arthritis. So let me just have a brief overview on that. So answer would be answer C, which is psoriasis. Now here see, it's a chronic arthritis. Okay, psoriatic arthritis is a chronic arthritis and it usually starts at a mild oligoarticular disease. Okay, it can become a polyarthritis also. Now it is a commonest comorbidity for psoriasis. Now psoriatic rash can be concomitantly there with this arthritis, or it cannot be there, or it can be initially the rash can be there and then the patient can get arthritis. Then investigation wise, the rheumatoid factor is again elevated. In radiography, you will get this pencil cup deformity, etc., etc. Okay. All right. So nothing much important is here. Just remember this psoriasis. So psoriasis can be tested in multiple ways. You could have been given the psoriatic rash and asked the diagnosis for this psoriatic associated comorbidities. Okay, next one. Evidence to suggest orbital for flow fracture. A, reduced eye movements. B, conjunctival hemorrhage. Now this will not be given as this. A clinical scenario will be given with a trauma case and some clinical features and asking for the diagnosis. So this orbital flow fracture is a common case that you get in trauma. A, reduced eye movements. B, conjunctival hemorrhage. Okay, so I totally forgot there was a question earlier to explain the erotomania and manipulation. So I'll explain it after this. I totally forgot it. Somebody asked me. Previous question answer, POPO IUCD. what I told is both are correct. POP and IUCD both are correct. You need further information. One information that you need is the duration. If she needs this for a short term, POP is a good option. If it is for a longer term, IUCD is better. The next thing that you can get is whether you need the best one. If they have asked for the best contraception, then copper IUCD, why? Its efficacy is high. Or else, if they have mentioned this lady forgets things and she doesn't want to take pills, then again copper IUCD. So we need further information. In your original exam, you will be given further information for you to guide or for you to select one out of the two. So with the information that we have, we can't decide on either of that. So both are correct according to our one. Okay, so now here. All right. Evidence to suggest orbital flow fracture. Now, orbital flow fracture is your common blowout fracture. It's known as the blowout fracture. Okay. Now, you should know the features of the blowout fracture because it's also, that is very important in trauma cases. Now, one sign would be periorbital ecchymosis, edema and emphysema around the orbit. Now, here you can see it. The next thing is infraorbital nerve anesthesia. So infraorbital nerve can be involved in your orbital flow fracture. So if the infraorbital nerve is involved, what would be the clinical manifestation? Can somebody mention? Can somebody mention what would be the clinical? Yes. Very good. Loss of sensation of the cheek, commonly your cheek. So that is a common symptom that you see. Sorry, it's not a symptom, sign. So infraorbital nerve involvement, you see the loss of sensation in the cheek. So that is one thing. Next one is ophthalmoplegia. Ophthalmoplegia is difficult or reduced eye movements. And because of that, they can have diplopia or double vision, specifically in up and down gaze. Then enophthalmos, if severe, that means eyes sinking into the socket. So these are like the common features of a blowout fracture. Now here, out of the answers that we have reduced eye movements and conjunctival hemorrhage. You don't get a conjunctival hemorrhage in orbital flow fracture. It would be ophthalmoplegia or reduced eye movement. So answer A is the correct one. Remember these key features of blowout fracture because it is tested at different times. Okay, next one. The picture of a forearm lesion was given. What is the management? A, local excision. B, wide local excision with sentinel lymph node biopsy. A is also wide local, but it's a local excision. B with sentinel lymph node. What do you think we should do? Can somebody mention the diagnosis here? Okay, there are different diagnoses given. Something it's a sebaceous cyst, something basal cell carcinoma, some for leishmaniasis, some for squamous cell carcinoma, some for keloid. Okay. All right. So I would say this is a basal cell carcinoma. Can somebody tell me why I told that? So what feature in this picture will tell you this is a basal cell carcinoma? Very good. I think Dr. Arya. Pearly white. This is a pearly, I agree you need more information, but see, this is a pearly white appearance. I don't know whether you can appreciate it. This lesion has a pearly white appearance, which is very suggestive of a basal cell carcinoma. And what category of basal cell carcinoma can somebody mention? Next thing is a telangiectasia. Very good. Telangiectasia is also there. And what Nodular, very good. Yes, Dr. Salma. This is a nodular basal cell carcinoma picture. This is not an abscess. Abscess will have a different picture. You will not have this telangiectasia associated with an abscess. Now, squamous cell carcinoma, it's usually the appearances is not like this. Okay. And the next thing was leishmaniasis. For that, you will have that lesion is also different to this. So, like you have to have a very good understanding of different skin lesions. Save those pictures and revise them regularly. Now, this has this pearly white appearance. I don't know whether you can appreciate, and this telangiectasia because of the increased blood supply. So this is a basal cell carcinoma. Now you should know, now we discussed about melanoma management in a previous record. How do you manage melanoma, the breast low thickness, etc., etc. So when it comes to the basal cell carcinoma, it is a non-melanomatous skin cancer. So your squamous cell carcinoma and basal cell carcinoma both belong to the category of non-melanomatous skin cancers. So you have a separate reference for the management of non-melanomatous skin cancers. So let's see how we are going to manage it. It's still loading. We'll wait. Okay. So this is again your RACGP. You have this basal scale, nodular, superficial, all those things, and it's squamous cells. Okay. Now you have different pictures for that. Now here see, this is a squamous cell carcinoma. Okay, again let me magnify it. Okay, now the first step would be the diagnosis. Now the gold stand would be your excision biopsy. So the thing you have, the management would be excision biopsy for the diagnosis. Then you will have margins. Then the excision would be your treatment. But if you can't treat it with an excision, then other options like curettage, diathermy, liquid nitrogen, and other options can be used. Okay, so that is for other options. Then special areas, eyes, nose, you have a separate management with precise excision. Okay, then you need to have a specific excision margin which you have to go through leisurely because it will take a lot of time if I explain everything. So go through this. So the what I wanted to tell in summary is your management would be a local or wide local excision. So answer would be answer A, which is local excision. Okay. All right. Now, before I move on to the next question, let me address the question which was previously asked about that erotomania question. Because okay, this one. There was a question to explain this again. Now here, this lady is calling the emergency. Now, what I was telling was, when you take erotomania, in erotomania, there is a condition. One person feels that the other person is, someone else is in love with that person. So if you take this lady, she believes that doctor is in love with her. So she would, and that is actually a firmly held belief, and that's a delusion. Okay. Usually that person is someone who is at a higher rank than her. Okay, 1 minute. Okay. Okay, 1 minute. All right. So that is erotomania. Manipulation is you are using something else to manipulate a patient to get something done. So if you need, for example, if you need a drug for some case, if you need to get a morphine or some addictive drug, you are trying to tell you will kill somebody or you are going to damage the hospital and you are going to get the drug. So your manipulation, you are going to get it, trying to get something by manipulating someone. Erotomania, you think somebody is in love with you, which is a delusion. Now, this lady thinks that former carer, former doctor is in love with her. So that is a case of erotomania, not manipulation. Okay, I hope I explained it clearly now. Okay, then. Okay, all right. So let's go for the next question. There was an issue with the chord prolapse one. So chord prolapse chart to show. So now this is the chord prolapse. I agree. This is not a very good diagram. It's not very clear. You can actually, I have mentioned the link. You can download it. This is NSW or somewhere. Yes, you can download it. Now what you have to do is you have to manually elevating the present part. That is not usually done. By putting hand, you are not going to do that. You are going to first position the woman in knee chest or exaggerated sims. Then you are going to lift the presenting part up. That is usually by filling the bladder. Because when you fill the bladder, the presenting part will go up. Now, cord handling is not advised because the cord can go into spasm. So you are not going to replace the cord into the uterus or into the cervix, but you can wrap the cord with a sterile gauze and keep it inside the vagina to prevent it from falling down. You are not going to manipulate it because the cord will go into spasm and it will create further problems. Okay, then you can consider tocolysis if necessary, but in our case, it was not necessary. So these measures are for you to prevent the cord from getting compressed until you do your immediate delivery. So until you get the theater ready for that, you are going to do this to prevent the cord getting compressed. Okay. I hope it is clear now. Sorry. And there was a question to tell the answer for the orbital fracture. Answer is reduced eye movements or ophthalmoplegia. Okay, let's do one. I think we have time. We can do this question as well. Okay, a cut of CT shows that liver get enlarged with multiple hydatid cysts. Asked what is the most appropriate management? A, metronidazole, B, laparoscopic drainage, C, laparotomy drainage. Sorry, here they have asked for the hydrated seed. They have asked for the most appropriate management. Okay, so they have not mentioned whether they are looking for the initial one or the best one, but since they have asked for most appropriate one, we can go for the best management here. Okay, so let's see. Now here you have the management for hydrated cyst. You can go for medical management and also for surgical management. Now here, the surgical management, so let me take you to that. Surgical management, that is specifically with laparoscopic therapy and puncture, laparoscopic aspiration, injection, that is shown to be like the most effective option for treatment of hydatid cyst. Okay, so that is the most appropriate, the best management. Okay, yes, you can try. Then let me take you to this. Etiology. Okay. Then All right, let me take you to the medical management. Okay, so all right, so here medical management, now even that differs based on you whether it's a cystic one or a gynecologist one, that you can go through literally. Then you have this chemotherapy. This is mainly for lung and liver cysts. Okay, that has different contraindication as such that you can leisurely read. But what you have to understand is the best management would be surgical, and even out of surgery, laparoscopy would be the best management, not the open one. So here metronidazole, yes, you can give metronidazole as an initial therapy. But since they have asked for the most appropriate one, you have to go for surgery. Even now you have laparoscopic drainage and laparotomy drainage. But out of those two, we have now discussed laparoscopy is the best one. So the answer would be answer B, which is laparoscopic drainage. Now this hydatid cyst, again, we did a recall, I hope, we did a question, I hope you can remember, to identify the hydatid cyst in a CT image. So you should know how to identify a hydatid cyst in a CT image and the management as well. So it's wise to have a good understanding about hydatid cyst, its investigations, management, etiology, and everything. Okay. All right. So I don't think we have time to go ahead with the next questions. So let's stop for today. I hope I answered almost. Is it necessary to give albendazole before aspiration due to risk of hypersensitivity? Yes. Because if the worm load is very high, there can be a risk of hypersensitivity. So in some centers, they practice this giving albendazole, but it is not always indicated. Sometimes you can go with the aspiration without albendazole. All right. So I hope everything was clear so far. Thank you very much for joining today. Let's end it for today, and we will meet. We will meet on another day with another set of questions. I hope things were clear. I tried my best to explain, but hope everything was clear so far. All right. So thank you for joining today. Let's meet on another day. So good night. Take care.